Welcome to MedLive. Today's program is It Isn't Just Skin, the Ins and Outs of Moderate to Severe Atopic Dermatitis. I'm Dr. Jonathan Silverberg. I'm a professor, director of clinical research, and director of patch testing at the George Washington University School of Medicine and Health Sciences. And I'm joined today by Dr. Andrew Alexis, professor of clinical dermatology and vice chair of diversity and inclusion at Weill Cornell Medicine, Sanaz Eftekhari, Vice President of Corporate Affairs and Research at Asthma and Allergy Foundation of America, and Christopher Aviles, a person with severe eczema, who will speak about his experiences. This program is presented by MedLive and the Asthma and Allergy Foundation of America in partnership with blackdoctor.org. Support was provided by Sanofi and Regeneron Pharmaceuticals. We'd like to hear from you during this program, so please take a moment to ask your questions by typing them into the box below at any time during the discussion. Please keep in mind that the questions should be general in nature. We're not able to answer questions about your case specifically, but we encourage you to bring those questions to your doctor. Throughout today's program, we'll also be asking you some polling questions. We encourage you to respond to these questions as it will help drive our discussion. And even if you're watching this video on demand after the live broadcast, it will provide valuable insight into your experience. As part of this program, we are conducting a feedback survey. We'd appreciate your participation in this survey, and your responses will help others affected by atopic dermatitis by revealing difficulties people face when seeking care, getting appointments, or dealing with other conditions associated with atopic dermatitis. Your feedback will help us develop future educational events, and your answers will be kept completely confidential. After viewing this program, the survey can be accessed by clicking the green button in the bottom right of the presentation. For your reference, the presentation slides are available for download in the event resources section of the player located under the video box. Here are our disclosures for the speakers. I'll keep that up for a second. And today's program will consist of 4 different modules. So module 1 is, what can I expect from treatment for my moderate to severe atopic dermatitis? Module 2 is, what happens in atopic dermatitis and why should it matter to me? Module 3 is participation in a clinical trial for me. And module 4 is accessing care and setting and maintaining goals for AD treatment, a panel discussion. Now, in this first segment, we will talk about what you can expect from your eczema treatment. So first is, what is atopic dermatitis? Atopic dermatitis, also known as eczema, is a condition that causes your skin to become itchy, dry, red, and bumpy, right? And those are very broad descriptions because it manifests in many different ways. When we use that term atopic, that indicates a tendency to developing allergies, and dermatitis would mean inflammation of the skin. The term eczema comes from the Greek word ekzine, which means to boil over or break out. And actually from sort of the original Greek, maybe more suggestive of like oozing and blistering than some of the chronic dry scaly eczema that we're often used to seeing. But that is the most common terminology used worldwide, is that eczema term. The disease usually starts before age 5 years. Often in infancy, although for some patients, it can persist well into adulthood. And for many patients, it can first appear in adulthood. So when is atopic dermatitis considered moderate to severe? Well, in general, moderate to severe atopic dermatitis is defined as about 10% or more of your body being affected by eczema lesions. And this is not a hard and fast definition. For some patients, it can be much, much more than that. And for some patients, it can be a little bit less, but it's affecting, certain key sites, like the face or the hands. So the location and the appearance of the rash certainly matter. But sometimes even when it's not so extensive on the body, the lesions can be incredibly, raised up, itchy, oozing, weeping, bleeding, just really thick, nasty lesions. And so even in patients who don't have it covering their entire body, but when the lesional severity is very, high, that also would put a patient into that moderate to severe category. And importantly, when the impact on quality of life is high, I mean, really, that's arguably what matters most, is how it's affecting the patient. That would also push patients into that moderate to severe category. In the end, the severity of your eczema or your child's eczema depends on, your experience with it. And open communication with your clinician can help guide treatment choices and improve atopic dermatitis. And I think this is really important because clinically I see this every day. There's a whole dimension of this disease that I, as a doctor, cannot see. I cannot appreciate unless I'm getting the patient's experience with their symptoms, with the impact on their sleep and quality of life. And so it's so important to relay your experience with the disease to your clinician. Now, who treats people with moderate to severe atopic dermatitis? Well, just thinking about sort of some of the different burdens that come up and the extended issues related to the disease, it starts to bring in a whole lot of other providers, and it's not just primary care doctors or skin doctors, right? So of course we have the pediatrician or primary care doctors. They're seeing the lion's share of atopic dermatitis because there's just not enough specialists in the United States and worldwide to see all the people with atopic dermatitis. We of course have dermatologists, skin specialists. We have allergists and immunologists that see many patients with atopic dermatitis, often those who also have the allergic comorbid issues like asthma and food allergies. We have mental health providers who are dealing often with the symptoms of anxiety and depression and other mental health sequelae of the disease. And then even nutritionists or dietitians, which come up, especially in patients who have true food allergies or who have food-related triggers of their disease. So this is a disease that holistically affects patients, and therefore there are many different providers across many different domains that need to be involved. So now let's take an audience poll. If you are, or your child is, a person of color with atopic dermatitis, how would you rate its severity when it's at its worst? Is it A, mild to moderate, B, moderate to severe, C, I'm not sure, the doctor hasn't said, or D, not applicable, I am white Caucasian, or don't have atopic dermatitis? And please vote now. And while the audience is voting, I'd like to ask you, Chris, if you could share your experience, tell us a little bit about the severity of your atopic dermatitis. I think you might be on mute.
Sorry about that. Thank you so much, Dr. Silverberg. I've had eczema basically my entire life and thus have experienced a whole range of different types of severity. When I was able to best manage my condition through treatments, it was very mild to the point where it was almost sort of unnoticeable. And so my quality of life was very good, and it didn't sort of affect my day-to-day. When it was at the other end of the spectrum, though, it was very severe. And a lot of the stuff that you had mentioned before was some things that I sort of experienced. I had rashes and blemishes about 80% of my body. I've experienced the bleeding and the uncomfortableness and sort of just did not feel well in my skin. It was very difficult for me to focus because of the itching and the constant achiness, as well as even falling asleep at night. In addition to some of the physical aspects and symptoms that I experienced, there was also a mental aspect of that where I was just embarrassed and just sort of like did not feel comfortable sharing parts of my skin. In the summer, I felt uncomfortable wearing short sleeve shirts. So it was both a mental and a physical aspects and difficulties in experiencing these symptoms and really sort of managing my condition.
Thank you for sharing your experience. And so turning to the audience polling results, the majority of the audience has answered choice B, moderate to severe atopic dermatitis. And I think, it just illustrates how commonly atopic dermatitis can manifest with moderate to severe disease. Okay, now we'd like to take a moment to view an interview clip with Linnell, whose teenage son has severe atopic dermatitis.
So during this time, my baby is not yet quite 2, and more of the surface area of his body is becoming covered with itchy bumps, itchy areas. He's not sleeping. He's even experiencing some pain and some bleeding in different spots. So we go to another dermatologist. We've met quite a few dermatologists, and at this point, he's diagnosed as having a severe case. So the level of steroids is being pumped up. They're telling us that we should try out a bleach bath. We should make sure that we're doing warm water versus cold water. They're recommending certain types of moisturizers that are slightly different than what we had. And at this point, too, he's also experienced several rounds of having antibiotics because he's developed some secondary infections from scratching areas. We're covering his hands, though, and we visited the emergency room several times at this point as well. So it's just getting worse. We're now 15 years in, and we're just at the point of assembling a team that is able to communicate and work for what's in his best interest.
So I think that's unfortunately all too common of an experience. So what are some situations that warrant a referral to a dermatologist? Well, your eczema or your child's eczema may not be responding well to treatment, or if you're not satisfied with the treatment it could be any number of reasons. You or your child may benefit from advice on specific treatments, including some of the newer treatments that are targeting inflammation. You or your child's atopic dermatitis is associated with severe and recurrent infections. And you and your child are experiencing social or psychological problems related to atopic dermatitis, and that may be part of a broader psychosocial impact of the disease, but that may also be because of things like symptoms of depression, anxiety related to the disease. And keep in mind, you can always ask for a referral. Now, when thinking about some of the basic treatments for atopic dermatitis, and this would apply really to all severities of the disease, from the mildest of the mild through the most severe. We certainly recommend moisturizers, to be applied not only on affected skin, but unaffected skin to try to prevent future flare-ups of eczema from happening. This is going to be most important during those times of year when the skin tends to be dry, like the cold weather, but really is relevant and useful all year long. Wet wrap therapy is a particular way in which one can apply their topical medications, where one can soak the skin in warm water, and then while the skin is damp, apply topical medications and then wrap the areas. And there's different ways in which this is done in different studies, but it could be wet cotton cloth, like the Curlex gauze type wraps that people have, cotton gloves or socks. Some will use sweatsuits, but it's the same idea. It's this idea of, getting the skin moist, putting on the medicine, and then, sealing it in, if you will, with a clothing layer on top. Dilute bleach baths are a little controversial, and they're actually now, I know there's back and forth and viral discussions on TikTok about some of this stuff. But, the rationale is to add a half a cup of bleach to a full tub of water and soak for about 5 to 10 minutes, usually we say about 3 times a week. And the thought is that this may help kill off some of the staph bacteria that are on the skin of patients with atopic dermatitis and may have benefits there. Now, when we think about moderate to severe atopic dermatitis, and truth is, even before we get to moderate, even in that mild category where the bathing recommendations may not be enough, where the moisturizers may not be enough, we would then go to usually prescription topical medications. So topical steroids are very commonly used. They're applied directly to the skin, affected areas, and can help control the itch and the inflammation and improve the healing of the skin when the eczema is resolved. But there's challenges with this, and we have to be careful not to overuse this, as it can thin out the skin, and that has its own problems that come with it. There are other non-steroid creams that are approved. There's something called topical tacrolimus and pimecrolimus. These are the official class, are so-called calcineurin inhibitors. They're good medications, but they come with black box warnings about theoretical risk of getting cancer. Topical crisaborole ointment is a relatively newer class of medications, generally thought to be very safe, but not always effective and at controlling the eczema, and sometimes can sting and burn, which can be quite limiting. Then we get into what happens when the topicals are not enough. And this tends to be in the more severe patients. Where do we go from there? And so there are other medications that can be reached. So oral steroids are one of the most commonly used class of medications to try to control severe eczema. And it's interesting because our treatment guidelines strongly discourage their use. We are not fans of using oral steroids as a general rule because they can come with a whole lot of side effects. They're a quick fix, but they're really not a good option for long-term use. And so our treatment guidelines really, again, discourage the use of it, other than in select scenarios or for rescue therapy. Antibiotics are sometimes necessary. We do not recommend these for the treatment of eczema per se, but when patients have a superimposed skin infection, a bacterial skin infection, then antibiotics are often necessary to control that underlying infection. And by reducing the infection, we can sometimes ultimately improve the eczema. Then we get into some of the different oral immunosuppressants. These are medications that will target the underlying inflammation that causes or drives the eczema flare-ups. And so we've got medications called azathioprine, cyclosporin, methotrexate, mycophenolate. These are older generation immunosuppressants, often used as transplant medications in much higher doses. They tend to be reserved much more for the severe patients. None of these are FDA approved for the treatment of eczema. These would all be off-label use in eczema, though we do have studies that have shown them to be effective, although all of the efficacy that we see is short-term. We don't have great long-term data, and they're complicated. Lab monitoring requires management by a dermatologist. Then we've got newer medications called biologics. And biologics are typically injectable medications that are so-called therapeutic protein that are used to treat or target specific aspects of the underlying eczema. And so now I'm going to move into newer treatments for moderate to severe atopic dermatitis. So first we have dupilumab. The other name for this is Dupixent. This is a biologic. It is FDA approved for the treatment of atopic dermatitis going back to about 2017. It's intended for adults and children now ages 6 months and up. We just got a recent approval down to age 6 months for moderate to severe atopic dermatitis who have not responded well to other treatments. And it's also FDA approved for several other conditions, including asthma, nasal polyposis, eosinophilic esophagitis. It's actually the first FDA-approved treatment for eosinophilic esophagitis. And it reduces the inflammation, but it's not a broad immunosuppressant like some of those oral medications that I mentioned a few slides back. But it's an injection. It's a small needle. It's generally easy to do, but it needs to be injected under the skin, generally speaking, every 2 to 4 weeks after a double loading dose for most patients based on their age and weight group. There are some possible side effects, overall very safe and well tolerated, but patients can get a little bit of injection site redness or swelling around where they're injecting the shots. They can get allergic reactions, rarely, but it can happen. And not uncommonly, patients can get almost like eczema around the eyes or just eye redness, swelling, itching that can come up. And it's something that we have to help patients navigate when they're on the medication. We also have a newer class of medications called JAK or Janus kinase inhibitors. And these are a little bit different because these are oral medications or topical medications, not injectable. And these are, the Dupixent works outside the cells, so to speak. These work inside the cells, but these do have more of an immunosuppressing effect. There are 3 FDA-approved treatments now that in this JAK inhibitor family for eczema. We have abrocitinib and upadacitinib as oral medications once daily. And then we have topical ruxolitinib, which is a topical JAK inhibitor, also approved for atopic dermatitis. And there are the way these were studied is different patient populations, but these have become new additions to our toolbox that are quite important. Now, with the JAK inhibitors, they're for abrocitinib and upadacitinib, they're approved for moderate to severe atopic dermatitis. So it's a more severe patient population who've already not responded well to other topical therapies and even other systemic therapies. Upadacitinib is approved for adolescents and adults. Abrocitinib is approved for adults. Ruxolitinib is approved for adolescents and adults, but with mild to moderate eczema. So it's a whole different ballgame in terms of what types of patients. This is going to be approved for a milder subset of people with atopic dermatitis. None of them are approved for treatment of other conditions like asthma. And they do come with some tolerability concerns around, stomach upset, nausea, vomiting sometimes, headaches. There are multiple black box warnings that come up for fortunately rare but serious concerns that come up around possibilities of serious infections, cancer, or even clotting disorders or heart disease. And there's differences between the different medications. And fortunately, again, the risk of these is very low, but it's not zero. Other warnings and things that need to be monitored are laboratory monitoring for just monitoring like blood counts and cholesterol levels. And this is not a medication one would want to be on during pregnancy. Officially, none of the medications are recommended for pregnancy, although there are clear differences between them for patients who are family planning. So let's take another audience polling question. How do you feel about playing an active role in making treatment decisions about your eczema or your child's eczema? And choose the response that fits you best. So A, that feels very uncomfortable to me. I want to be a good patient and not make life more difficult for my doctor. B, I do what the doctor says because they are the expert. C, I do as much research as I can so I can have an informed opinion. Or D, I'm the one who has to live with the treatment, so I express my opinion and I expect to be listened to. So please vote now. All right. And so it looks like the majority of the audience is answering B and C. So a little bit of a mixture in terms of, being involved and taking an active role in that shared decision-making process, and some taking a little less of a role. And I think that's totally reasonable. There's different, every patient is a little bit different in this respect. All right. Now let's go to, what medication is best for me? How to decide, with your doctor about what's best for you, what's best for your child. So, what to tell the doctor, would be about your symptoms, how often you get flares, how it's affecting your life, and which aspects are particularly the hardest to live with, and what your treatment goals are, what you hope to expect, why you want to get, treat the underlying eczema, and also recognizing and acknowledging that this is something that, if you've had it for a decade or more, even if you've had it for 6 months or more, a quick fix of a 2-week treatment is nice for 2 weeks, but it's not going to be obviously adequate in the long run. So expressing your desire to have a good long-term treatment plan, acknowledging and having an open discussion about the possibility of side effects, what you're comfortable with, what you're not. I always tell the residents, I could prescribe anything, but if the patient is not comfortable using it, what's the point, right? So, and then, just explaining how often you're putting on the medicines, how often you're using them, do you miss doses, what you can really fit into your life. And then, of course, there's a variety of different questions that you can ask your doctor related to these in terms of, what are some of the newer treatments that are out there, and what can you do for flare prevention and not just treating flares when they come. What are the safest options? What are the most effective options? What are the risks and benefits that come with this? And, what can you do to try to get away from the steroids in order to minimize some of those side effects? All right. So here's another polling question. What is the most important to you to discuss with your team when making treatment decisions? And for this, I'll just read the answer choices and I'll let you vote. A, is it side effects? B, how well it usually works? C, quality of life. D, convenience. E, how it's taken. Was it a pill, injection, topical? Or F, the ability to access and things like cost and affordability. And while you're voting, I'd love to get your opinion, Chris. How would you answer this question? And if you could tell us a little bit about your experience with some of these different aspects.
Sure. Thank you so much, Dr. Silverberg. So I think for me, quality of life was definitely a big issue, especially when my eczema was sort of most severe. That was sort of at the forefront of my mental process. And in terms of treatments, as my eczema went through different stages and different severity, I also went through different types of treatments myself. I started off with the dermatology topical creams and doing the wide range of things without steroids to things that were at the very high range of steroids, depending on the areas that were inflamed. And as those actually began not to work, sort of escalated my treatments to things like phototherapy, which was something that was also something that I had to manage as well. In terms of being able to sort of get to those places where that was being offered. And then to the extent that I was also going into the injectables in order to sort of manage the real severe cases that I've had.
Understood. And so let's see what the audience says. And I think we're seeing alignment between your experience and how many patients or our respondents or audience are thinking about this, because the majority of the audience is answering sort of a mix between A, side effects, B, how well it works, and then F, in terms of access. And we know these are all such important issues that need to be addressed. All right, so moving to the next part of this discussion, I'd like to turn it over now to Sanaz to discuss some of the additional aspects and considerations.
Thank you, Dr. Silverberg. And we'll move through these a little quickly. But what can you expect? As you guys saw from the last poll, the most important thing to you could differ based on your life, your quality of life, and what you expect. So the most important thing here is really to make sure that you're talking with your doctor. You need to be an active part of the decision-making process. I know Dr. Silverberg mentioned a term called shared decision-making earlier on. And that's really important because you are the expert in your atopic derm or your child's atopic dermatitis. So it's really important that you speak with your doctor, talk through what you're expecting, and make that decision together. looking at the long-term goals of AD, for a lot of people, it's not just easing the flares in the moment, but looking at a little bit more of a long-term vision of what do we want to make sure that the goals of this treatment are. And here are some of the examples on the screen. So just make sure, again, that you're being an active participant in this discussion, you're talking it through with your doctor, and the two of you together can come to that conclusion about what you want to try and move forward with. And Dr. Silverberg, I'll pass it right back to you.
Thanks very much. So in this next section, we'll talk about what happens in atopic dermatitis and why it should matter to you. And I'll turn it over now to Dr. Alexis to discuss this.
Well, thank you, Dr. Silverberg. It's my pleasure to take over this next section and talk about, well, what really happens in AD, really at the skin level, and why should it matter? And I think when you understand the mechanisms of this condition and what it looks like in its various ways, various ways it can present, you can have a better understanding of your own condition and be able to advocate for yourself and understand what your treatment options are and why. So when we look at atopic dermatitis, just looking at it visually, one of the first things that you notice is it has such a varied appearance, depending on the age of the patient or the location on the skin or the patient's own complexion or their racial ethnic background, their ancestry. All of this can play a role in variations in what atopic dermatitis or eczema actually looks like. Now, if you were to go into your browser and look for pictures of atopic dermatitis, unfortunately, you will see a predominance. You won't see that much diversity in terms of skin type or racial ethnic background. You'll see a majority of examples in lighter skinned individuals, where you see bright red, scaly, excoriated, meaning scratched rashes or lesions, as we call them as dermatologists. Now, when we look at the broader spectrum of diverse skin types, different complexions, we see that there are variations in color. It may not just be red. It may be red-brown. It may be shades of gray, shades of violet or purple. And another thing that we notice is that once the eczema, the scaly, itchy, bumpy rash resolves, it tends to leave behind some area of abnormal pigment, usually in the form of excess pigment, like brown patches, as shown in the bottom right of the slide. This we call post-inflammatory hyperpigmentation. However, the opposite can happen. You might have areas of lighter pigmentation as a result. And so these pigmentary changes can last for weeks to months, even years in some cases, long after the eczema that caused these patches resolve. So this adds to the overall burden and experience of dealing with atopic dermatitis when one has skin of color. Now, when we look at the epidemiology, we look at population statistics and see how common atopic dermatitis is, we actually see differences in different self-identified racial ethnic groups. There are multiple studies that are shown in the United States. Black children, self-identified Black children have a higher rate, higher prevalence of atopic dermatitis compared to other self-identified racial ethnic groups. And this is just one study that we're showing here, with 19% of Black children in the US having atopic dermatitis compared to lower numbers in white children and Hispanic children, according to this one pediatric study involving 50 states. There are also numerous studies that show that atopic dermatitis tends to be even more severe or have a greater burden, greater impact on various populations of color. More frequent visits, evidence of poorer control, visits to the emergency room for flare-ups, limitations in access to treatment have all been shown. So why are these differences? Why would there be differences between eczema in one group over another? And the answer is, of course, like most things, it's very complex, and we don't fully understand. We don't have all the answers, but we do know that there is evidence for variations in genetic factors. There are some genes that affect the structure and function of the skin, including the barrier function of the skin, and these seem to vary from one population to another. There are differences in environment that is certain. Environmental exposures to different triggers can certainly vary from one population to the next, and variations in access to specialty care and access to medications that would be useful for atopic dermatitis all play a role in what we actually see as far as variations in severity and prevalence. So this is an area of ongoing research to better understand why we have these differences. So let's take a look under the hood and see what really happens at like the molecular level when it comes to atopic dermatitis. And while this slide looks very complicated, lots of arrows and colors, the bottom line is what you're seeing here is a schematic of the skin. And from top to bottom, the top layer, this is the top layer of the skin. And there are issues of the barrier function of the skin in atopic dermatitis. The barrier function of the skin, which protects the skin from losing water across the skin barrier, is impaired. So there are breaches in the barrier. So the consequences of that is more water loss across that skin barrier. It is also an entry point for pathogens like bacteria and viruses and allergens, which can then stimulate a whole set of downstream inflammatory and immune responses. As we go to the bottom part of the slide, this is like the deeper part of the skin called the dermis. All sorts of things going on, upregulation of immune factors. And the most important thing is this green and white circle that says Th2. There is increased activation of this pathway in the immune system called Th2. And this drives a lot of the factors that we see with eczema, the itching, the barrier dysfunction, including dryness and scaling, and all the various manifestations of eczema. So Th2. And Th2 responses are important, not just in the skin, but also in other organs like the airways. And this contributes to asthma, allergic rhinitis, nasal polyps, a gastrointestinal disorder that is allergic in nature called eosinophilic esophagitis, or EOE. So having eczema might put you at a higher risk of these other conditions that are also mediated by the same immune pathway called Th2. And this is why it's so important to treat eczema comprehensively and effectively. So let's take a minute and ask another audience polling question. Which of these conditions do you or does your child have in addition to atopic dermatitis? Asthma, food allergies, hay fever, chronic rhinosinusitis with nasal polyps, eosinophilic esophagitis or EOE, other conditions, or G, none that I know of. And as you're taking a moment to answer those questions, we have my patient, a patient of mine that I've had for many years and who's generously devoted his time for this session. Chris, could you speak to any of these other conditions that you might have in addition to your eczema?
Sure, Dr. Alexis. So in addition to my eczema, I also suffer from asthma. Again, ever since I was a young child, and similar to my eczema, it's had different stages of severity, from being very dependent to things where I've now sort of like am less dependent on medications and can sort of deal with it on a regular basis without having to take, the emergency inhaler situation.
Great. Yeah, thank you for that, Chris. And so let's see what the audience has said. We got the poll results in, and it looks like the majority of the audience is answering A and B. So asthma and food allergies. And yeah, that's pretty consistent with my experience too. Although I'm surprised I didn't see that we're not seeing C, hay fever right up at the top too. But all of these conditions can be seen together with atopic dermatitis. So thank you for answering that question. Let me move on to the next slide, which I'd like to introduce another vignette. This is from a caregiver, experience with atopic dermatitis and related conditions from the caregiver's perspective.
So early on, my son was diagnosed with food allergies. His first food allergy that he was diagnosed with was dairy. He was and is to this day allergic to both proteins, casein and whey. And he was also diagnosed with a peanut, tree nut, fish, shellfish allergy, as well as eggs and wheat. So he had quite a bucket load of allergies, which made both treating the atopic dermatitis and just him purely enjoying food and activities kind of challenging. As he got a little bit older, we participated in clinical trials. We were participating in a clinical trial when we discovered that he had developed hypertension. Part of the workup for the trial was taking blood pressure, and his blood pressure was extremely high for even an adult. So we wound up in the emergency room, and they diagnosed him there with further testing and diagnosis by his actual pediatrician and a nephrologist who treated and still treats him to this day for his hypertension. We cannot say for sure, but as a child who's been on oral and topical steroids pretty much since birth, the possibility that the hypertension is linked to his atopic dermatitis and steroid use is extremely great.
Thank you so much for that outstanding presentation. And so now in this third part, we'll discuss clinical trials. And so what are clinical trials? Well, the research studies that are carried out by expert doctors and researchers, the goal of which is to find new treatment options or new uses for current treatments. And, importantly, they don't just look at efficacy, but they look at safety. And maybe safety is even more important than efficacy for any new medication that comes about. How does a clinical trial help you or others with atopic dermatitis? Well, it means getting access to some of the newer treatments that you might not be able to have access to for several years afterwards. This can be particularly important if there's barriers to access and insurance issues, or if you've tried other therapies and they failed, this gives you new options to think about. You can help others by helping to find new treatments. So your participation in a trial will teach us more about how people with eczema respond to these different therapies, and that ultimately helps the greater good. And you get more frequent and closer monitoring of your symptoms and any side effects because you're going to be coming in on a more regular basis than is often the case for typical clinical encounters. So we will now hear from Linnell about how she found a clinical trial for her son.
Because my son has been severe for so long, I spent a lot of time on the internet. The internet's one of my very best friends, and I search around for different information as it relates to eczema, and I like to look at clinicaltrials.gov. So I searched through clinicaltrials.gov to find some clinical trials that were related to what was going on as far as his eczema. Because the plan is never to just stay and have eczema and treat it at that point, but to get to a point where ideally it's cured, but anything that's as close to looking like being cured as possible. So my son was super uncomfortable, and I searched and I found a trial, and I called the researcher and talked to the researcher about the trial, and then we went in.
Yeah, so Linnell is a very engaged and active caregiver, is looking into this. It's not always as easy as it seems to navigate the clinicaltrials.gov website, but I applaud her initiative. Let's take another audience poll. So what best describes your main concern about participating or having your child participate in a clinical trial? And choose the answer that fits best. Is it A, not applicable, I have no concerns, sign me up? Is it B, I don't know anything about clinical trials or how to find out about them? C, I think it's probably really time consuming, I just don't have the time. D, they probably get a sugar pill anyway, so I don't see the point. E, I just don't trust the process, I won't be or have my child be a guinea pig. Or F, some other concern that may come up. Please vote now. But I'd like to ask Chris, while the audience is voting, to speak about challenges, that you found for participating in a clinical trial and, whether or not you'd be willing to participate in a trial if things lined up for it.
So as Dr. Alexis mentioned, we've been working together for several years. He's someone that I really trust. And so we've actually talked about clinical trials a few times, and he has sort of like recommended them a little bit. And so I've sort of like, again, having that trust, sort of have been very willing to be a part of a clinical trial. One of the things that have sort of impeded me in being able to participate in them was actually twofold. One was that once we had spoken about them, a lot of the clinical trials that were sort of like open and available had already started. And once a trial has started, you can't sort of just participate in it because it's already sort of in process. So that was one of the things. And then the second thing, which I think was also very relevant, was just life. So I sort of like work full time. I was going to school at that time as well. I had a younger sibling that I helped manage and sort of take care of. And so finding the time to participate in these clinical trials and being able to sort of get to them and sort of go through the process of them was very difficult, and sort of managing my sort of day-to-day and sort of life routine.
Yeah, I mean, I think those are very spot on. They're great options for patients, but they're not for everyone. I mean, it has to fit within the rest of your life and how to build that all in. So thank you for your experience. Okay, and the majority of patients or respondents are answering B, I don't know anything about clinical trials or how to find out about them. And I think that is, because they're not being done out of every practice out there. But I think it's, if nothing else, you walk away knowing that there are options and things to potentially think about. And it's worth sort of exploring if you need to. All right. So we're going to go quickly through the next section, which is, participation of diversity within clinical trials and why it matters. There's a cynical saying that clinical trials are designed for old white men. And the reason where that comes from is because when you look at the breakdown of participants, it's often older white males. We need to understand how therapies work across different age groups, races, genders, ethnicities. And so diversity in clinical trial participation is really important for us to understand how well a treatment works across different populations. And there may be differences in how drugs work in different patient populations. We've seen this come up in a lot of different disease areas, and we've even seen a little bit of that come up with some of the newer therapies for eczema. So, we want to have as broad and representative of a patient population in the trials to really understand how to apply it in the real world. How are we doing? Well, I mentioned some of this already. When you look at the majority of clinical trials, there's an overrepresentation of white participants, and we tend to have, not zero representation of other racial subgroups, but often in the context of a clinical trial, not enough for us to really get a robust understanding of how the drugs are working across different subsets of patients. And, another way to potentially look at this is compare the breakdown of the racial breakdown of participants in trials with the breakdown of race in the U.S. population. And what we see is that there is a little bit of an imbalance there, that there is an overrepresentation of white participants in trials relative to the proportion they represent in the U.S. population. So some myths and facts about clinical trials. Some of the myths are, I'll need to leave my doctor to participate in a clinical trial. Not necessarily. That your doctor may be an investigator in the study and certainly can coordinate with the investigators in the study. And you can follow up with your doctor for routine skin care or other care anyway. That's part of standard of care outside of the trial visits. The trial is going to take forever. Well, some trials do take a long time, but most have a fairly reasonable schedule of visits. You know up front what you're going to get. They tell you exactly when the visits are. It's all pretty scheduled in advance. So I think there's a lot there. And we definitely have so the slides are jumping on me here. And so you have additional information about the trials and some of the myths and facts that are over here. One of the things that came up is, would people participate again in a clinical trial? And in one study, most volunteers said that they would participate again, really indicating that they were satisfied with the experience overall. So I think that's very telling that this is something that can be a good option for many patients. And so I'm going to turn it over now to Sanaz to discuss a little bit more about how we can find out about clinical trials.
Thank you, Dr. Silverberg. So a clinical trial is no good unless you know about it. So if you're a person impacted by atopic dermatitis or you have a child impacted, what's the best way to find out about AD clinical trials? Let's start with your doctor. So we've got Dr. Silverberg and Dr. Alexis here, who are both investigators in different clinical trials. Chat with your doctor. Like Dr. Silverberg said, they might be an investigator, or they might know of trials happening. So your doctor is always a great place to start. And then what do you need to know about participating? So the first thing is whether or not you or your child are eligible to participate. And often you're going to hear about the eligibility criteria. And what that means is for studies to be effective, in order to study a specific treatment, you're going to have to adhere to certain criteria that would include or exclude you from a trial. And so these are conversations you can have with the investigator or the clinical trial team to see whether or not you even are a fit or even eligible to study in the first place. And as you're having that conversation around eligibility, you'll also have other conversations just around logistics. So these are some of the questions to ask about the clinical trials if you're interested in participating in one. So let's talk about what's the purpose. Let's talk about just the logistics of timing. Let's talk about risks and benefits. So all of these are really important for you to talk with your doctor or, again, with the clinical trial team. But always start with your doctor and see if they can connect you with a trial that's happening that you might be a good fit for. And with that, I'm going to pass it back over to you, Dr. Silverberg.
Thanks very much. And so in this section, we'll have a panel discussion about accessing care and maintaining, and setting and maintaining atopic dermatitis goals. And so with this, let me advance to the next slide. Let's start off this section with a clip from Linnell, who's going to discuss access to care.
I would count us very fortunate in terms of accessing care, because through our time in dealing with my son and his atopic dermatitis, I've met other people that have really experienced challenges. I think early on, because we visited so many different types of doctors, we learned about prior authorizations and different types of pharmacies and patient assistance or patient assistance programs and those kinds of things, and samples that really help you. Do I think it's been really expensive? Absolutely. So had we not had insurance, I see so many holes. There's so many places where it would not have worked. And even with our insurance and the flexibility of our insurance, it's still been expensive.
Yes, all very, very important insights. And so now I'll turn it over to Dr. Alexis, who's going to lead the panel discussion.
Thank you, Dr. Silverberg. And, that vignette that we just heard, it touches on a very real world situation that we see time and time again. And that is, sometimes we present as clinicians, we present these options, these treatment options that we think might be good for our patients, but then due to insurance factors, other factors, cost issues, our patients just might not be able to get the treatment that we recommend. And, this is an experience that I had personally with my patient, Chris, time and time again. So I'm going to turn it over to Chris to just speak to some of the challenges we've had in terms of getting on therapy. But we've also had successes, haven't we?
Yes, definitely. Thank you so much, Dr. Alexis. So I want to sort of mirror a little bit of what Lynn said, because I have also been fortunate enough to have insurance and have sort of different types of coverages. But there have been some difficulties, especially when going into the upper tier of treatment Most specifically, the injectable medications were very costly, and the insurance company that I did have would not cover it. And so there were several processes, and again, thank God for Dr. Alexis, of sort of helping me walk through the appeal process and really sort of going back to them and sort of going through the process of trying to get the medication. We've landed at a point where the insurance company would still not cover it, but we were able to get into a program that allowed me to receive the medication for some time for free. So that I would still be able to sort of reap the benefits of the medication. And it was a very special program. There was an income cap on it. And it was interesting that I had actually received a sort of like bonus at my place of work, which put me over the cap of that special program, and then sort of pushed me out of being able to receive the medication again through this special program. And so it was a very sort of daunting experience to be sort of like, again, in this boat of not being able to receive the medication and sort of like spiraling down in terms of my skin condition. And we've sort of had to sort of, again, sort of go through the process of identifying additional accesses for other injectable medications because I had experienced such great benefits from that type of medication.
Yeah, thank you, Chris. It just speaks to the complexity of the landscape of trying to get medications covered. But thankfully, there are indeed resources, and with enough persistence and navigation and advocating, you can ultimately get the treatment that you need. And it's really something that both your doctor and yourself can work together on to get that right treatment. In the interest of time, I'm going to just turn it over to Sanaz, who can talk a little bit more about some programs that exist in terms of accessing medication.
Thank you, Dr. Alexis. And so the truth is, treatment may be expensive. And you've heard Chris and Linnell talk a little bit about their experience with some of these challenges accessing the right treatment. But a good place to start usually is with the manufacturer. Oftentimes, and I know you heard Linnell mention patient assistance programs, a lot of times manufacturers have programs that you can apply for to help pay for either part or all of the treatment. So it's always a good place to start. And after that, if you find out you aren't eligible, or for any other reason the manufacturer programs don't work out, you can always turn to other options. So there are local, state, and federal government programs, and there are a few listed on the screen. There's also some nonprofits who are really great about helping pay for some of those treatments that may be too expensive. And for those that you may not be eligible for the manufacturer programs. So always feel free to reach out to some of these nonprofit organizations or these government programs to help you pay for some of the treatments if needed. If you need additional support, even just around, if you need a emotional, psychological support, just to talk to others who have been through similar experiences. The Asthma and Allergy Foundation of America does have an online patient community. You can sign up at aafa.org/community. We always welcome anyone with experiences with atopic dermatitis, and we also have a lot of folks with asthma, allergies, and other comorbid conditions. Another great resource, of course, is the National Eczema Association. We work very well with them, so we recommend them as well. But just make sure that you're reaching out to some of these resources that are available. And with that, I'm going to pass it back over to Dr. Silverberg. I think we have time for a couple of questions, maybe.
Yes, thanks very much. So we have some of the questions starting to come in. And I think while we're waiting for some of the questions to come up, one of the questions that has come up just in general and that we've discussed already in a sense throughout the presentation is, we can say that we have a specific question that's come in from the audience. Are the differences in the skin that influence the severity of atopic dermatitis in patients of African descent? And this would be, I guess, let Dr. Alexis, if you could take this one.
Sure, I'd be happy to. So the question is about, are there differences in the skin and the structure, function, physiology of the skin that might influence the severity of atopic dermatitis in patients of African descent? That's an excellent question. There are some studies that have shown differences in some components of the skin barrier. For example, a natural lipid that's an important part of the skin barrier called ceramides actually, because there's different types, tend to be lower in the skin of individuals of African descent compared to individuals of white or European descent and Asian descent. So there are a couple of studies that have shown that, and that might be one example of why we see differences in severity and prevalence of dry skin and eczema.
Excellent. Thank you. All right. So we have another question here. Should children with moderate to severe eczema have allergy testing? Maybe Dr. Alexis, if you'd like to take a quick stab at this one.
Sure. I think it's a great question about allergy testing for atopic dermatitis. And it's really, there's no one size fits all answer. If there is a clue that there are triggers that might come from allergens, whether environmental or food, where every time you or your child is exposed to a certain factor, whether it's in the environment or by diet, that your eczema flares. Well, that's an important enough clue to start digging deeper and performing testing to see if there is an association. As a general rule, when it comes to foods, that tends to be more relevant for children, for infants and children, and is less of a factor in adults. So it really depends. It's case by case. Dr. Silverberg?
Excellent. Yeah, no, completely agree. Our guidelines really discourage the routine testing for food allergies, but in tougher cases that are just not responding well to therapy, or when you have those clues, those would be the situations where we would recommend food allergy testing to potentially be done, or air allergy testing. And likewise, also patch testing can come up similarly when there's other clues, like certain localized areas of eczema that are just not sort of responding well to treatment as well. We would think about skin allergy testing too. So, all right. And a question here, are there any clinical trials focused on treatment of atopic dermatitis in patients of African descent or other diverse patient populations? So maybe Dr. Alexis could take this as well.
Yes, Dr. Silverberg, if you could just repeat that question.
Sorry, I read it quickly. Are there any clinical trials focused on treatment of atopic dermatitis in patients of African descent or other diverse populations?
Excellent question. To my knowledge, at this moment, I'm not aware of studies that are specific to individuals of African descent. The current studies enroll more broadly. And then what happens is post hoc, as we say, after all the data's in, and we then drill down on the different racial ethnic groups. But I agree with the person that asked that question. I think we do need studies going in the future that specifically look at individuals of African descent with atopic dermatitis.
Yeah, I completely agree. And I'd say what's encouraging, because now we're just starting to see the design of studies specifically for skin of color. And so it's really a first, and it's welcome, but it'll take years till we have the readouts, but I think it should be very good. All right, so we have one more question I think we can take just for the sake of time. And I thought, here. This is for Sanaz. What opportunities do I have to self-advocate for my child or loved one for atopic dermatitis care?
So I'm going to say you're starting at the right place just by joining this program, really just helping educate yourself and, to take the best care of yourself as a patient or your child as a patient. In addition, the Asthma and Allergy Foundation of America, we are a nonprofit patient advocacy organization. I mentioned the National Eczema Association. They're also a patient advocacy organization. So groups like ours, you can reach out to us and see what's the best way to educate yourself and your family more on atopic dermatitis, dermatitis. And this is in conjunction with what you do with your physician. So we're not replacing any relationship that you have with your doctor. But in addition to that, how can you do more on your own? But also, like, how can you help advocate even for better policies, whether it be at the federal level or state or local? You can definitely work with organizations like AAFA or with NIA to learn a little bit more about advocacy and policy opportunities as well. So I know that was a lot to throw at you, but it was really just more education in general, but also a lot of work on advocacy as well.
Excellent. Thank you so much. And thank you again to all of our presenters, Dr. Alexis, Sanaz, and Chris, for joining us today and providing us with a really informative discussion. Thank you, of course, to our audience for joining us for this special patient education program. And I'd also like to thank the Asthma and Allergy Foundation of America and blackdoctor.org for their partnership on this program. Support for this program was provided by Sanofi and Regeneron Pharmaceuticals. Please complete the questions at the end of this program. And as a reminder, please see the event resources section of the player located under the video box to download today's presentation slides. And this program will also be available on demand. My name is Dr. Jonathan Silverberg, and on behalf of all my co-presenters, I'd like to thank you for joining us. Have a wonderful day.